Okay, this is the HCM-associated cardiac troponin T mutation K280N accelerate tension generation and relaxation in human cardiac myofibrils. Cardiac troponin T is a troponin complex subunit involved in regulation of muscle contraction. HCM-associated cardiac troponin T mutation are responsible for particular severe forms of the disease, often associated to sudden cardiac death, also in young people. We investigate mechanical and kinetic properties of myofibrils from a cardiac interventricular septum samples of an homozygous patient carrying the troponin T mutation K280N undergone cardiac transplantation. So we compare our myofibril from this particular homozygous sample with two control groups. The first one from 4 patients, a ventricular sample from healthy donor hearts, and the second group is from 7 patients with secondary hypertrophy, and we use ventricular sample from this patient undergone aortic valve replacement. We use single myofibril or a small bundle of myofibrils, and the useful technique is that myofibrils permit us to work with the smallest subdivision of the contractile apparatus of the striated muscle, retaining the entire ensemble of associated proteins. Myofibrils are also easy or quite easy to isolate from any striated muscle, including the human cardiac samples. And then we can work with minute size, and that permit to go in rapid equilibrium with bathing solution in less than 1 millisecond. For that reason, we can work with a fast solution switching technique. This is a scheme of the procedure that we use for our experiment, and we mounted myofibrils. We attach myofibrils between the 2 glass microtools, a force probe used as a cantilever, and a motor. At the beginning of the experiment, myofibrils is perfused by a relaxing solution, that means without calcium. After a quick displacement of the injection pipette, myofibril is quick perfused by an activating solution, that means with high calcium concentration. This is a typical trace obtained by our experiment, and we can see that after the immediate movement of the pipette, we can observe the increase of the tension generation, the raise of the tension to a plateau value. This phase is described by a constant that is K-act, that describe the kinetic parameter of the raise of the tension, and in particular describe the rate of tension generation. A similar constant is KTR, that describes the raise of tension after a quick mechanical perturbation. The third part of the experiment is again a quick movement of the injection pipette, so that myofibril is again perfused with a relaxing solution, and we can observe the relaxation phase. So quickly I explain this phase. This is characterized by 2 different phases. The first one is a slow linear phase, and the force decay occurs under isometric condition of sarcomeres in absence of calcium. This is described by the duration and by a kinetic parameter. The slow KRL, in fact, is the apparent rate with which attached cross-bridge leave force-generating states under isometric condition. The second phase is the fast phase. This is an exponential phase that doesn't occur under isometric conditions, and describe the give of the sarcomere reflecting intersarcomere dynamics. So using this mechanical parameter, we analyze our samples. The first parameter analyzed is the tension, and we found that maximal myofibril tension is significantly decreased in the sample with mutation compared with the group of donors myofibrils, but it is not significantly different from that of the secondary hypertrophy samples. The second parameter analyzed is the kinetic of fourth generation, and now it's clear in both parameters describing this kinetic activation that in the mutant samples, the rate of force activation in these myofibrils, in the mutant myofibrils, is significantly faster than in controls. And here we can see clearly that this happens for K-ACT and also for KTR. Finally, we analyze the relaxation kinetic in this mutant. In general, we can see that all the relaxation kinetic parameters are accelerated in this mutant, compare both control groups. But in particular, the kinetic parameter that characterize the relaxation part, also all this sample, is that the slow KRL is strongly accelerated in mutant. As to the fast KRL, we have seen that this parameter has the same trend of the slow relaxation phase. So summarizing this first part, we have seen that maximal active tension is lower in the mutant myofibril than in donors. Then we have seen that there is a marked increase of K-ACT in mutant myofibrils compared to donor, and the slow KRL is markedly faster in K280N myofibrils compared to donor. Overall, we have seen that the relaxation duration has a variable behavior. So the second part of our experiment is based on some exchange experiment. In fact, we perform two different kinds of exchange. We use a human wild-type troponin complex for two different replacements of the protein. The first one, in the first experiment, the human wild-type troponin complex exchange experiment were performed to test whether alteration of the sarcomeric function in mutant myofibril can be rescued by replacing the mutant protein with a recombinant wild-type protein. And the second exchange experiment was done to check for potential alteration occurring with protein replacement method using the same troponin complex into donor myofibrils. The troponin complex replacement in myofibril suspension was performed at 4 degrees overnight in a regular high calcium solution, and the exchange was done by mass action. We use a mixed troponin T, a recombinant mixed troponin T that allows exogenous troponin T to be distinguished from the endogenous protein on the gels. So we can evaluate the extent of the troponin T replacement, and in our case, in both gel, that means for troponin T mutant and for the donor, the extent of the replacement is around 70%. So it's a good, is a successful replacement. So we analyze the parameter, the kinetic parameter, and firstly we can see that after the troponin replacement, the myofibrils restore value similar to the control control myofibrils. In particular, we can see an interesting things that after the exchange with the wild-type troponin complex in the donor, the parameter, this kinetic parameter, remain the same. We can see that we have a significant recovery of the donor parameter also for the KTR. as the relaxation kinetic are also slowed down in mutant myofibril following troponin exchange. So slow KREL is reduced and become close to that of control myofibril also in this case. So summarizing this second part, we can see that there are no significant difference in mechanical properties and kinetics of activation and relaxation between untreated donor myofibrils and wild-type troponin exchange donor myofibrils. We can see also that wild-type troponin exchange in mutant myofibrils restore K-act close to control values, and the wild-type troponin exchange in the mutant myofibril restore also the slow KREL close to control values. So this result indicate that the HCM-associated cardiac troponin T mutation accelerate the apparent cross-bridge kinetic, in particular the apparent rate with which cross-bridge leave the force-generating states. So this result of replacement of the wild-type complex into the mutant myofibril suggests that the kinetic changes observed in the HCM myofibrils are directly related to the troponin T mutation. These kinetic alterations associated to the troponin T mutation can lead to increase energy cost of tension generation that may be central to the HCM disease process. Data collected by Rosalie Paal-Berens in Jolanda van der Velden group in Amsterdam support our prediction. She performed measurement of ATPase activity on the same troponin T mutant that we used for our mechanical measurements. She performed this experiment using the ATPase activity measured by a couple enzyme assay. That means that what is measured is not directly the ATP consumption, but the couples enzyme assay of the degradation of the reducted form of NADH. This is a photometrically measurement of the ATPase activity. That means that the fall of NADH concentration was determined photometrically, recording the decrease of the reducted form of NADH absorbance of the solution from emerging bean. The sample is a skinned sample. The measurements are conducted under isometric condition and is mounted between a force probe and a motor. Those are the results. This is the two direct measurement. The first one is the tension, where we can see clearly that the tension is reduced in the troponin T mutant compared to the two control groups. And the second direct measurement is the ATP consumption, where also we can clearly see that there is a significant reduction of the ATP consumption in the troponin T mutant compared to the two control groups. So from these two direct measurements, we can obtain the tension cost that is obtained dividing the ATP consumption for the tension, and is clear that in the troponin T mutant the tension cost is significantly increased compared to the two control groups. So concluding, faster cross-bridge detachment under isometric conditions and therefore also higher energy cost of tension generation had been previously reported in myofibrils from a patient carrying a particular severe mutation R403Q in the motor of the myosin, and recently confirmed by directly measurement of isometric ATPase rate in skinned preparation from the same patient. So faster cross-bridge detachment under isometric condition and so higher energy cost of tension generation may be a common feature to several HCM-associated mutation independently of the exact specific mutation and sarcomeric protein involved. So concluding, increased energy cost of tension generation may be a central feature to HCM disease. Thank you.
So I have two questions. I wanted to ask you whether the duration of the slow phase of relaxation is always the same from one myofibril to the other, and also between different samples. This is my first question.
Okay. The duration is a parameter that is still, we are still analyzing. We found some difference between the samples, the Troponin T samples, but we cannot see a big difference between the Troponin T samples and the mutant samples, and sorry, the control samples group.
Okay. And the other question is, did you have the opportunity in Amsterdam to measure the ATPase activity after the rescue protocol? I mean, after the exchange, let's say, not yet? Okay. Yeah. Thank you.
Quick question. This is obviously homozygous, so you have 100% mutated protein.
Yeah.
So in clinical practice, you do have heterozygous disease. What is the percentage of mutated to wild-type protein you would expect in a generally in troponin disease?
Sorry, what?
What is the percentage of wild-type to mutated protein you would expect to find in a sarcomere
in these samples?
In troponin disease in general? Because you have to hypothesize a Poisson effect in order to, rather than haplotype insufficiency.
It's variable. It's a variable percentage.
May I ask you one question? There's no one else. I'm a clinician, so I need your help to make up my mind. So in the 90s, it's been shown, the NIH group showed that myosin mutations impair contraction. Yes. This led to a theory by Ali Marian, by which impaired contractility leads to release of growth factors such as TGF-beta1, IGF-1, and there's evidence for that. And so hypertrophy is like secondary hypertrophy. The mechanism is the same. Then alpha tropomyosin mutation have been shown to increase contraction. And if I'm not wrong, your results go in the same line. So how do you interpret the mechanisms? Which is the pathophysiology? Is this some kind of starvation, cardiomyopathy, or
I think
why is there hypertrophy?
Each mutation has to be considered alone. We cannot generalize. Usually each mutation has a particular feature, so that means that we can find on the same protein different mutation, and the behavior, mechanical behavior in my case, could be different. So it's a little bit difficult to explain in a general way.
If I may add something. No, I think there was a story about hypocontractility, hypercontractility. In our hands, the results we get, if we look at maximal force that can be produced, it is always either reduced or the same as in secondary hypertrophy. So I think there may be also still some idea of a reactive hypertrophy to low force. Hypercontractility in our hands is a faster kinetics rather than a stronger force. And looking at the data, you expect some energy impairment of the cardiomyocytes. That maybe not the unique cause of the disease, but may be important in several cases.